Well, hello, everybody. I have an amazing guest for us today, my dear friend, Dr. Alexis David. And so she is one of the top board certified obesity medicine physicians in the outer greater Seattle area. She founded the premier medical weight management in Bellevue. She co-founded, just FYI, the Washington Obesity Society and was the first president. And of course, a Seattle Met top doctor for 2024. We are going to talk about obesity today, right? So my name is Dr. Arinola Dada. Welcome to the Healthy Joints, Healthy Lifestyle Show. For those who don't know me, I am a rheumatologist and I help people with joint pain become pain-free so they can live healthy, active lives. So welcome to the show, Dr. Alexis David.
Oh, thank you. Thank you, Dr. Adada. I really appreciate hearing that intro. I kind of, lose track of all the things that we've done here in this space. But I'm really excited to be here and be a guest on your podcast.
Okay, I'm also going to give you an opportunity because I know I did not do your resume any justice enough. So I would like you to introduce yourself to our guests and maybe talk a little bit about why you do what you do.
Okay, great. Yeah. So, I originally I called myself as a family doctor for over 13 years, working in primary care, and I loved doing primary care. Prevention medicine is really my true calling, and I've always had an interest in treating weight. I graduated from medical school, did my residency. Completed residency 20 years ago now, and back then they weren't teaching us very much about weight. And even though I had an interest in it, I will say a lot of the things that I learned about it um, really have been turned on its head, a little bit
Yeah,
upside down, if so
yeah.
to speak. And fortunately, in 2017, I attended my first Obesity Medicine Association conference. And through that organization in 2017, really became so excited about treating weight and viewing obesity as a medical condition that deserves to be treated, and realized as I learned more and more how important it is to treat this as a chronic medical condition and not just as a precursor to other diseases.
Yes.
And that led me, over the course of that year, I became board certified. I became a diplomat of the American Board of Obesity Medicine while maintaining my family medicine, while working in primary care full time, and also, being a mom to two kids, right?
Yeah.
Um, and then
Super
through
mom.
that journey, I kept going back and forth. Am I going to stay in primary care? Am I going to be part of this big system and
Yeah.
serve a greater audience?
Yeah.
Or do I want to do this and maybe have to my hands tied with how insurance requires us to
Mm,
manage it?
yeah.
Or do I want to do it the way I think people deserve to be treated? And so that led me the basically as I was taking my board exam, also giving notice to my practice because I decided to open up my doors. And the summer of 2018, um, founded Premier Medical Weight Management here in
Yeah.
Bellevue, Washington,
Yeah.
Seattle suburb. And I have dove head in and I haven't looked back, and I'm so glad I did. This is such a rewarding space. And
Yeah.
so I really have been thankful to have gotten in when I did. I've learned a lot along the way. I
Yeah.
continue to learn, right? I'm a
Yeah.
continuous learner about the disease of obesity, and I'm happy to share that information with my patients every day and hope to help open up, some eyes and some ears
Yeah.
as your guest today too.
Yeah, perfect. I've actually sent patients of mine to you, right? And they
Mhm.
have, so
Yes.
we are also grateful in my clinic to have you as a resource because I have sent number of patients to you. I remember there's a patient that had to lose weight so that she could get her knee replacement done, and you did it. But
Huh?
she and I had been struggling and battling with that. And I just said, you
Mhm.
know what? We need Dr. David here to come and help us because that's what she specializes in. And you did it. She got her knee replaced and we got the weight down and she had to do, and then she was able, because the surgeons were not going to touch her because
Yeah.
she
Yeah.
needed to get that weight. Remember her? Yeah.
Yes.
Yeah.
Yes.
Yeah.
No,
So we've had,
I,
yeah.
yeah, I appreciate all the referrals, and I also encourage my patients who need a rheumatologist, to see
Yeah.
you and your
You do,
colleagues
yeah,
there.
you do a phenomenal job. So we are grateful to have you in Bellevue
Mm-hmm.
area. That's for sure.
Yes.
So we are going to dive right in. So, what makes, before I start that, I kind of, it resonates, right, about what we were taught in medical school. And which honestly is calories in, calories out, right?
Mm-hmm. Yeah,
Right? And a different form of
exactly.
calories in, calories out. Never mind what kind of furnace you have, right? But
Right.
anyway, let's dive into it. I'm going to let you kind of, because I still need to learn so much about this. So,
Oh,
what makes obesity a disease? And how
oh,
does it
an
differ? Yeah, how does it
yeah.
differ from just a matter of like personal choice and a little bit of willpower?
That's right, right? I mean, we've been told and fed our whole lives, and also most of us in medical school or other medical training, that it is calories in, calories out. And, I that was the advice I was taught. That's the advice I was giving early in my career as a family doctor who didn't know any better. And and those people who don't struggle with the pathophysiological condition of obesity, it makes sense, and the body, it works, right? So someone who doesn't have this chronic condition or disease that develops for some people early in life and others it's over time, excuse me, you know, it doesn't, it's hard to understand, right? Because if I make some changes or adjustments into what I'm eating, how much I'm eating, or when I'm eating, or how much exercise I'm doing, or a variety of factors, I'm lucky in that my weight responds for the most part, right? And someone such as yourself, I know you're very focused on your health and you do a good job, right? We're able, our body regulates our weight within a regular, a
Thanks.
range,
Yes.
just like our blood pressure,
Yes.
just like your heart rate,
Mm.
just like your temperature and your respiratory rate.
Yeah.
Guess what? It is regulated in the primitive brain, in our hypothalamus, in our brainstem, that we have no willpower over.
Hmm.
Okay. Very limited, very limited.
Yeah.
And anywhere outside of this range,
The
right, it's going to be
stress.
harder and harder
Yeah.
to manage. The problem is, we're not, you don't think about your temperature unless you're sick. You don't realize your blood pressure is high sometimes unless you go to the doctor and
That's
it
true.
gets measured and it's elevated. Now, I mean, I could talk, I have a lot to say. Let me try
No,
to,
please. No,
you know,
continue. This is, yeah,
but
this is important information here.
so what our body does is it regulates not just our weight, but also our fat mass.
Yeah.
And there is a very complex interplay between the signaling between our brain and the different organs in our body. And when I was in med school, I'm sure when you were in med school, I was just taught fat, what does it do? It just stores energy. That's about it. Move on, right? We maybe had an hour lecture on it,
Yeah.
if that. And now what we know, it's the largest endocrine system in our body,
Yeah.
that our fat cells, they secrete inflammatory signals and other
Yes.
respond to different hormones or neural, transmitters that regulate between our brain, between our pancreas, our gut, our liver, our stomach, right? And our muscle and our fat cells.
Yes.
And it's this regulatory system
Hmm.
that we think of all the brakes and the gas pedals
Yes.
that keep us in a regular, a regular range,
Yes.
and that homeostasis, right? And as
Mhm.
long as the system is operating smoothly, there's no pathophysiology involved, all is fine. Just like your blood pressure or your
Yeah.
temperature, right? But if
Hmm.
something happens and then the teeter-totter scale, it starts to tip one way or the other, different signals are going to be emitted from our brain and interplay with our organs and the hormonal neurotransmitter axis, right? And that it's very much like let's say your thermostat in your house, right? Or your HVAC system. And if you try to regulate it, if it's too hot or too cold, you say you want to heat at this level and cool at that level, right? And as long as it's working properly, it's fine within that range. The same with our weight. And we used to think, high blood pressure nowadays, people understand if it gets out of normal within a few visits with your primary care doctor, they're on you and you realize, I'm worried about my blood pressure. I got to get this treated, right? Because we know of all the consequences and health risks
Yes.
associated with that.
Mm-hmm.
Well, back in the 1950s, we used to think it was all in our head, that we were all stressed out.
Yes.
And if you would just relax, your blood pressure would come down. And they
Mm-hmm.
used to hospitalize patients for their blood pressure
Yeah.
and
To rest.
and prescribe bed rest.
Yes.
Right? Because back then we didn't have all the wonderful, amazing medications that we have and tools and understanding that we have now.
Yes.
And where we're at with this disease of obesity is like the 1950s or 60s for
Yes.
blood pressure, right? Where now only, we've had, previous anti-obesity medications prior to the GLP-1s coming out, but only now, because of this great success, are we really hearing and talking about it, and layering that on top of the COVID pandemic and, the much higher disease and mortality rates
Mm.
among those who had obesity really forced us, I think, to recognize it, not just as a risk factor for other
Yes.
things, but brought it more to the forefront of the headliner of like, look, hello, this is a chronic disease that deserves to be
Yeah.
treated.
Yeah. So let me ask, so when we're talking about the thermostat, right? When we're talking
Yeah.
about flock, we're talking about the body kind of wanting to keep the weight. Is that what we're talking about?
Right.
That
The thermostat.
our body wants to keep the temperature of the room at a certain, so wants to keep the body's fat at a certain level. Is that what
Correct.
we're talking about?
That's what we're talking about,
Yeah.
is your body is wanting to regulate and maintain this
Body
normal
fat.
range, or what
Yeah.
it believes is normal,
Yeah.
right?
For it.
And
What
yeah,
it's
and
used to. Is it what it's used to?
right. So for some people, since childhood, they've just either never felt satiated or full, or they've always had some like yeah, I'm sorry, just insatiable hunger and
Yes.
food noise, right? And
Mm-hmm.
they've never felt full a day in their life.
Mm-hmm.
Or maybe they had experienced perhaps some trauma in early
Mm.
childhood, or some life habits of the family where, we celebrate with food, we commiserate, we culturally, we're
Yes.
like, oh, we had a bad day, let's get some ice cream. We had a good day, let's get some ice cream,
Yes.
right? And so there's some societal impact of
Yeah.
that. And over time, we've let it maybe gotten to a higher weight. Also, with that regulatory center, there's a lot of brake pads or stop signals to keep us from losing too much weight. So the
Mm-hmm.
signals are different, okay?
Yes.
Whether or not you struggle with weight your whole life, or
Yes.
maybe a certain life event happened, or after pregnancy or having a baby, or having a child, of
Mm-hmm.
your spouse having the baby, or um your partner, and for whatever reason, maybe more stress in your life, there's many factors
Mm-hmm.
that influence the signaling pathways. We
Yeah.
interpret stress as a stimulus. We there I
Stress.
like I said,
Yeah.
I could come on and talk a lot
Yeah.
about each individual one of these
Mm-hmm.
things, but suffice it to say that there's a lot of different signaling,
Mm.
and we are protected against starving to death. That is
Yeah.
priority number one.
Yes.
Because if you think about it, way back when how we evolved earlier
Yeah.
times, you lived through periods of feast and famine. You had to hunt
Mm.
and gather for food,
Yeah.
or we didn't have it, right? So we
Yeah.
did, part of the fat and mechanism is the storage of energy.
Yeah.
The problem is we're not tapping into it because we're constantly having this influx. So there's so many things that have changed: our
Mm.
environment, our stressors, the kinds of food we're eating,
Mm.
how much activity we're getting in. All of
Mm.
these factors play a role, but then there's very strong prevention to keep us from losing too much.
Yeah.
But the what keeps us from gaining too much is kind of weak. And when you've done,
Yeah.
day in, day out,
Yeah.
month in, year out, over
Yeah.
time, we maybe
Yeah.
gradually over time continue to gain, the average
Yes.
this is pre-pandemic off the top of my head. Average person gains about four
Yeah.
to 5 pounds a year.
Yeah.
And then maybe we'll lose a couple, but the net gain is maybe 2 to 4 pounds
Wonderful.
gain a year, right?
Mhm.
If we're not staying on top of it with our current modern day environment, we live
Yeah.
what we call an obesogenic environment, right?
Yeah.
Modern day,
Obesogenic environment.
we live in an obese like it is, you're going against the
Yeah.
cultural societal grain. If
Yeah.
you are trying to be healthy, what's wrong with you? Why won't you eat this? If
Yeah.
we're
Have a
trying to
drink.
eat, yeah,
Relax.
why aren't you
Mhm.
drinking with me? Why aren't you eating with me? Or and our all our stressors and our sleep. So let's multiply that over years and years. The
Yeah.
longer we've lived at a higher weight,
Mm-hmm.
our body kind of gets like a broken thermostat. It doesn't
Mm-hmm.
necessarily recognize that we're at a weight that's high for us and unhealthy for us. It's just we've lived here for however many years. The longer you've lived there, the more it protects against it.
Yes.
And when we do try to restrict our diet and exercise a lot,
Yeah.
we're going to lose to a certain point, but those
Yes.
signals to keep us from losing are so
Yeah.
strong that
Yeah.
they override. It's our primitive brain. It's not our forebrain. It's
Mm.
not our willpower.
Mm-hmm.
We can't just say, sorry, we need to reset the
Mm-hmm.
thermostat.
Yeah.
No, it's not responding to that. It's
Mm-hmm.
broken. And sometimes people are able to make, as that's why we need to make consistent lifestyle changes. The thing that we do to lose the weight needs to be continued to keep
Yeah.
it off.
Consistency. Yeah,
Yeah.
this is so helpful. So, just to kind of pull back a little bit, I think one of the things that I actually is new to me is
Mhm.
I always knew that, yes, we were hunter-gatherers back in the day. And because we were hunter-gatherers, the main objective of our system was do not die, do not starve to death. So all the
Right.
things that our body needed to make sure that we did not become skeletal, it was like
Mhm.
store, store, store. But I
Right.
really never really thought about the fact that on the other side of that thermostat, there was no reason, the body is very efficient. Why
Mhm.
was a human going to need to be protected from being overweight? That's not your
Right.
problem. That has not been our problem for centuries. So there is
Right.
no need to waste anything. Even if we had it at the beginning of mankind, that probably evolved into nothingness, right?
Right.
Because there was never
So
any reason, right?
there
So,
are signals there, but
yeah,
they're very weak
very
and
weak.
they're
Yeah,
very
that's, yeah, yeah. So the signals
they're
are very
easily
weak.
overridden.
Yeah,
That fullness sense cue,
yeah,
but how many of if you try to feed a child when they're
yeah,
younger, they never finish the plate on their,
yeah.
what's on their plate because as they listen, they pay more attention to
Listen to
those cues. Like,
those
I'm full, I'm
cues.
done. Like, no, I don't want to eat that,
I
right?
don't want to,
And
yeah,
but a lot of us grew up, we don't waste food, right?
yeah.
You remember the clean
Yeah,
plate
so the
club, right?
cues are
So a
less
lot of us,
strong. The
we learn
fullness, mm-hmm.
we learn to override those
Cues,
signals
mm-hmm.
so much so that
Are
we
weaker.
don't even pay attention to it. We don't
Yeah,
even realize that they were
yeah.
there, let
Mm-hmm.
alone the societal pressures, the communal things, right? So
Yes.
there's
Yeah.
so many changes with our environment, not to
Interesting.
mention the food, right?
Yeah.
And then
Mm-hmm.
there's peer pressure sometimes, like, I'm not hungry, but if you're at an event, you
You,
don't want someone
yeah.
to feel bad, or
Mm-hmm.
so there's
Yeah.
so many reasons why we
Yeah.
eat.
Mm-hmm.
The main one is to nourish our body, but think
Yeah.
about all the other reasons why.
Yes.
Um, it's very
Very
complex,
interesting.
right?
Yeah, it is. It is
hmm
for
And
sure.
we
Wow.
inherit different predispositions, right? You can
Yeah.
have genetic predisposition
Mm-hmm.
to storing weight more easily, which would be
Yeah.
great if you had a really long famine, right?
Yes.
We were selected for
Yes.
over the millennia
Mi-
to
Because we could
survive
store.
famine.
Yeah,
That's
you could
right.
store. Yeah, we're
Exactly. Uh-huh.
storers. So we
That's right.
survive.
So we have to, recognize how good we are at storing. And so we
We
have
are
to tap into
get
those
an A for
stores.
that. Yes.
That's right. I'm very good at it too,
I'm
myself.
very good at it, that's for sure. Okay, we're gonna move to, so what are we talked about it a little bit, I think, kind of the main biological and medical factors that contribute to obesity. What do you think?
Yes. Oh, so there are many factors. There's, and some of them apply to some people and not others, but there are epigenetic, genetic factors. When you were a baby in your mother's womb, what was the metabolic environment like? That can influence,
Mm.
your metabolism as an adult.
Mm-hmm.
Your own medical conditions,
Mm-hmm.
some that maybe affect you. You're not able to be as active, or you
Mm-hmm.
have inherit a predisposition to having high cholesterol or type 2
Mm-hmm.
diabetes, or having,
Yes.
been exposed to some virus, or for whatever reason, having diabetes from a young age, to the societal pressures on, what eating, and mental health, emotional factors. Sometimes, there's a strong correlation with mental illness and obesity. And, sometimes there's iatrogenic, medical conditions. Sometimes the medications that we take to treat some of these factors cause weight gain unknowingly, perhaps to the prescriber. Um, and there's some things that we have control over, and there's some things that we don't, right? And so we have to recognize the complexity of it, and, appreciate, I am who I am. I cannot change what's happened in my past, but I can work to take action on the things that I have control over, right?
Yeah.
And I think sometimes learning, a lot of people come to me with this, what we have as our society is a diet mentality. We
Mm.
have to restrict, diet and exercise. And unfortunately, that's also written into some of the requirements for some of our medications. And, it is true. We have to be careful about how much we're taking in. But the most important thing is what quality and kind of
The
calories are
quality,
taking
the
in.
quality
Yeah,
of the calories, right?
exactly.
Yeah, the
And
quality of
having
the
some
calories.
balance in that. Yeah.
Yeah. So
You know,
quality and balance.
quantity
Yeah.
and balance. And you can have a really healthy,
Quality.
high quality diet,
Yeah.
nutrient dense. I always talk about making sure we're getting in the right nutrients in
Yeah.
our foods,
Mm-hmm.
and being mindful of the high energy but nutrient poor
Mm,
foods, right?
yes.
So we try
Yeah.
to limit how often we're exposing our body to those, and try to
Mm-hmm.
maximize the good quality
Yeah.
macronutrient balanced
Yeah.
nutrient dense foods our
Yeah.
body needs.
Of
We
high
need to get
calorie.
in the
Mm-hmm.
protein, right? And so
Mm-hmm.
sometimes when people restrict so much,
Mm-hmm. And
that our metabolism
mm-hmm.
slows down in response to that, right? So
Yeah.
on average, you're going to maybe lose 5 to 7% of your starting body weight.
Yeah.
And then those protective mechanisms are going to kick in. Your brain is going to override any of that willpower stuff that you have to protect you from starving to death.
Starvation. Yeah. Yeah.
Yep.
Yeah.
It does
Your
not
brain will not
recognize,
allow you.
yeah, it
Mm-hmm.
doesn't necessarily recognize that we still have more to go, right?
Mm-hmm.
And our
Yes.
muscles, you can exercise all you want, but our muscles get more efficient, right? And
Yes.
as we lose weight, there's not as much work for those muscles
To
to
do.
do.
Yeah. So
Yeah.
they start, well, we don't have to work as hard, so we don't have to burn as many calories. So la
Yes.
di da da.
Yes. So, all of those things. Okay. And
Mhm.
then there's, the effect of stress and the
Mhm.
stressors that our body interprets chronic stress as a threat to
Yes.
survival. And when we're
Mhm.
under stress, the area in our brain interprets that as we need more energy, or we
Mhm.
need to conserve energy. It's a
Mhm.
threat.
What
And
is
so, yeah.
stress? So what I mean, stress is so difficult to so when you say stress, tell me more. What are we talking about? Because I think it's for some people stress can be, or is it just any stress? So stress can be, I didn't sleep well last night, I'm stressed. All right. So what kind of stress are we talking about in this situation?
Um, Whatever causes you stress.
Mm-hmm.
Yeah, the way that your body interprets as a worry or a concern or something that does affect your sleep. If our sleep is affected, it slows down our body's
Yeah.
metabolism and increases our hunger hormone
Yeah.
and our olfactory nerve, our
Yeah.
sense of smell, and our
Mm-hmm.
cravings and thoughts of food increase.
Yes.
We're more sluggish, we're less likely to move around as much.
Mm-hmm.
And that's all a protective mechanism based on our brain, the
Mm-hmm.
primitive brainstem, to keep us to conserve energy, because it
Yeah.
interprets that as a threat to survival, and a
Yeah.
threat you need to conserve, right?
Yeah.
And any stress that we have way back when, if you think about evolutionary times, you typically, our stressors at the time was a facing us or behind us, right? As a threat, or we were either going to
Yeah.
chase and hunt something down, or
Yeah.
we were the
Oh,
one being
we are
hunted
being
and we had to
haunted.
run, right?
Yeah. Yeah.
That fight or flight that we
Yeah.
learned, yeah,
Yes.
that. So what happens? Our cortisol increases,
Yeah.
and we mobilize our energy, right? So
Yes.
we mobilizing energy.
Yeah.
And as long as we're using it, no problem, because then we're
Yeah.
using that. But in today's modern day environment,
Yeah.
it's very rare for our stressor to be physical in the fact that
Yeah.
we're running or, chasing
Yeah.
something.
Yeah.
And it's more likely to be chronic day in, day out. We're more likely to be on a screen of some sort,
Yeah.
reading and getting stressed out over
Start
it, or
from
work
that.
stress or
Yeah.
family stress. I'm worried about my family. I'm worried
Yes.
about my parents. I'm worried about my kids or my cousin or my friends, loved
Yeah.
ones, whatever
Yes.
it is
Mm-hmm.
that we can't stop,
Stress has
thinking about.
changed.
And that worry that
Mhm.
also motivates and mobilizes the energy.
Mobilizes. Yeah.
Correct.
Yeah. Okay.
Yeah, and that day in and day out, that chronic stress, especially if we're not getting out the energy with that, well, we tend to see more easily central abdominal weight gain. See an increase in visceral fat. We also tend to see, therefore, because visceral fat is more inflammatory, we see
Yeah.
greater inflammation markers,
Wow.
right? And that just perpetuates the cycle.
Mm.
And, also
Wow.
when we're more stressed, we have less sleep,
Wow.
which then also perpetuates. So it
But with that
becomes this
cycle,
vicious
yeah.
cycle.
So yeah, so the stress has changed too. So the stress has changed from one that elicits action into one that is more kind of emotional, but doesn't really elicit the action. And then with the high cortisol, we can't burn it as we had in the past. And then we have just kind of more abdominal fat storage, high cortisol levels, and then whatever your body can do with it because it's not really being like put out there. We're not running, we're not chasing anything. That's interesting. I had not even thought about the fact that I know that our stress has changed for sure, but I had not even thought about that affecting, well, what does your body do with that energy that comes from the
Right.
stress?
Right. And so that's where we are seeing increased waist circumference, abdominal circumference,
Mm.
and and measures of visceral fat.
Fat.
I at my office, I do body composition on everybody, and I do it every visit unless I never force anyone to get on the scale.
Yeah.
There's a lot of different emotions around weight. Sometimes we're stressed over our weight, right?
Yeah.
And that like it continues the cycle, right? So but I do measure visceral fat, and when I'm treating somebody, I really am prioritized, focused on trying to lower not just our weight, but our fat mass.
Fat mass.
That is really the key, is to lowering fat mass and doing our best to maintain our
The
muscle
muscle.
mass,
Yes.
our bone,
Yes.
our other,
Density. Yes.
there's so many, staying hydrated. So we have to make sure we're doing this without starving ourselves and
Yes.
making sure we're staying well nourished.
Definitely.
And so, I mean,
Yeah.
I have a lot to say, but I would say this, it's really important, if we're struggling with this
Hmm.
condition, to
Yes.
recognize that, it's not all doom and gloom. If I go by the OMA, their definition of obesity, it's a chronic, progressive,
Mm.
relapsing, recurring, but
Mm.
treatable
Treatable.
disease.
That's the hopeful part. Yeah, because all that chronic relapsing,
Yes,
recurring. Okay,
right?
treatable. Okay, thank you for that.
Yes,
Treatable disease. Okay.
yes.
So on that note, as we're going from the fact that yes, it's chronic, it's recurring, but it is treatable, can you
Right,
tell us, Dr. David, what are the most effective medical treatments for obesity beyond good old diet and exercise?
right. So I always say in my practice, we have the four pillars. You want to say four or five pillars of treating weight
Yes.
and managing that. And the first two, we talked about nutrition, activity.
Yes.
There's the behavior component
Yes.
where we're managing stress. We talk about managing stress and
Yeah.
sleep because those are very
Yes.
important. Then the fourth is medications, and
Yes.
the fifth, which they try to combine, is also maybe considering surgery. So
Yeah.
up until recently, the most effective treatment by far is bariatric surgery. And
Okay.
there's been a lot of advancements with surgical treatment. Um, and they've gotten really good at it. But the
Yeah.
problem is a lot of people don't want to have bariatric surgery.
Yeah.
And up until recent years, with our latest, the newest generations of anti-obesity medications, our first generation anti-obesity meds, we had the oral meds like the phentermine, the Qsymia, the Contrave, or perhaps a combination of some of those generic medications. There have been others that have come and gone that maybe they were approved and they worked well, but after a while, they've been since taken off the market due to safety concerns,
Yes.
which then raises everyone's level of concern about safety risk. Oh, I don't want to hurt myself by
Yes.
treating my weight. But fortunately, we have the latest class of these GLP-1s, right?
Yes.
GLP-1 medications have been around for at least 15 years to treat type 2 diabetes. So we've got good data there.
Yes.
And some of the earlier generation ones, we had Saxenda, which was a daily one to treat weight that just became approved for a generic this year. But it's a daily injection, and the average is about 12% weight loss. So
Mm.
better than the orals, but not quite, say, as much as the surgery, right?
Yes.
And then you move to the weekly injectable GLP-1 of like Wegovy or semaglutide, which many
Yes.
people recognize as Ozempic, which was for diabetes. But with that, the average, we see a range of 16%. Now,
16.
people's response to these medications are going to vary depending upon how much are they doing these other three pillars
Yeah.
of the foundation of treatment. And then with Zepbound or tirzepatide, also known as Manjaro, which is for type 2 diabetes, that I would say is, it's a combination GLP-1 and GIP hormone, which
Mm-hmm.
on average we see about 18% weight loss, give
Okay.
or take.
I didn't know
I
that.
have seen a range of 10% to 25 or 30% weight
Wow.
loss. And a
On
lot of it
Zepbound.
depends on the individual person, how they respond, but it also depends on how much they're following this comprehensive treatment program.
Yeah.
Yeah.
Interesting. Yeah, I actually didn't even realize that there was even that much of a difference in kind of the percentage body weight loss, even between the different novel weight loss medications. Can you talk a little bit about how that's impacted like bariatric surgery then?
Well, I have to say I don't closely interact with the bariatric surgeons, but from what I've heard,
Mm-hmm.
I think initially there's been less drive for bariatric surgery
Yeah.
because people want the medications. And then I think, but we're starting to see it maybe come back a little bit more
Mm-hmm.
in because people who then did maybe perhaps get started on a GLP-1,
Mm-hmm.
but maybe lost their coverage or couldn't afford it anymore.
Okay.
This is a
So,
chronic condition. The
Dishan.
treatment needs to be continued, just like blood pressure medicine,
Yeah.
unless something changes. And
Yes.
so there's been some people who then, recognize or realize maybe I do need to have bariatric surgery.
Mm-hmm.
And I have had patients who've lost a significant amount of weight on a
Yes.
GLP-1,
Mm-hmm.
but then were out of concern or fear or due to a change in insurance,
Insurance. Yeah.
then go opt in for the surgery. But I will say, even people who have bariatric surgery, we do also struggle with the long-term
Um,
weight management. And if
yes.
we lose track of how we're eating, how
Yeah.
we're moving, how we're
Yes.
managing our stress and our sleep and all those other behaviors, the
We can
societal
still
component, we can still regain
get
on
that
that.
back. Yeah. They.
Sometimes we need to use multiple different medications, right?
Mm-hmm.
So, I think there has been, some increase in bariatric surgery. There's some, insurances that's all they cover because,
Mm-hmm.
as you know, unfortunately, our country still views treatment of weight as a cosmetic issue
Mm-hmm.
and not
Yeah.
as a chronic disease.
Yeah.
There was just, there's been a Treat and Reduce Obesity Act that's been a bipartisan supported bill
Mm.
literally since before the pandemic, where now it's in 2025.
Yeah.
Um, there was this rule, the CMS rule, with the previous administration in November of 24. It did pass to bypass that and then view obesity as a chronic disease, which would
Yes.
then require Medicare to cover it.
Yes.
But they require a 60-day waiting period to enact that. And now we are waiting on the new administration to see what they're going to do in response to
Well,
that.
yeah, and you've been a strong advocate of patients, I think, in our groups, and I also signed that just in support of the
Thank you.
latest legislation just to make sure that our patients are getting access to the care that they need. I'll just say that, we are really looking, even in the world of rheumatology and inflammation, at a
Mm,
high people who have excess adipose tissue. And we're really looking at that as a cause for inflammation. And a lot of
yeah,
conditions, as you probably know, like psoriasis and chronic
yes,
psoriatic arthritis, are actually being treated with something like Zepbound plus their biologic medication and are getting dramatic improvements than they would with one or the other. So really, strongly support your advocacy work for
thank
patients so that we can get patients the care that they need. So thank you, Dr.
you.
David.
Thank you. Yeah, I'll just say there were 14 states that required the coverage for the treatment of obesity. Washington State currently is not, but they do have that bill, Senate Bill 5353, which I did testify and encouraged a lot of people to support in. We are they're going to be reviewing it later next year. So
Okay.
hopefully within 2
Hopefully.
years, we'll see.
Okay.
But
Okay. It
in
takes a
any
while,
case, we'll
huh?
continue our efforts. What I just would like to end with is making sure that someone who's recognizing, maybe listening to this, recognize that it is a chronic medical condition. We don't
Mm.
expect you to figure out your cancer treatment by yourself. We don't expect you
Mhm.
to figure out your rheumatological treatment by yourself
Yeah.
or your blood pressure treatment by yourself. So why would we expect you to figure out your weight treatment by yourself?
Yeah.
And we have to be careful about the compounded formulations. There's a lot of risk associated with those. There a lot of inaccuracy. There's a 30% variability rate in terms of the strength. And a lot of people who are getting these prescriptions for compounded meds online are not being followed closely enough. And they're not being monitored as regularly as they should be. And there's been a lot more complications. So a lot of the scary headlines that we see oftentimes,
Mm.
but a lot of the times it's related to the compounded use. So I would encourage someone to seek out someone who's certified in obesity medicine, whether it's a physician or a nurse practitioner or a PA. There are different certifications for the different provider levels. Seek someone out who's certified, who knows what they're doing, and work with them.
When you say scary headlines, what are those?
Oh, some liver disease, kidney disease,
Interesting.
pancreatitis. There's potential there. People are not recognizing the dose or the strength they're taking, and sometimes they think, oh, if a little bit is good, I'll just take more. They are maybe jumping around in their doses too much, getting not. We started a low dose and taper up for a reason, and if they suddenly do that, they get into this cyclical vomiting issue,
Oh my
and they
God.
may develop acute kidney damage
Oh
or liver
wow.
damage,
Yeah.
and they can't eat or drink. It's really, really scary.
Wow.
But
Mhm.
the risk, any headlines that come out, it's like, well, we know that's a potential risk, but I counsel my patients and then make sure
Mitigate
they're
that.
fully informed before and they know
Hmm.
what to expect. And
Yeah.
so the headlines don't sound as scary to them once they've
Yeah.
had a fully informed consent
Yeah.
decision-making process.
Okay, okay, that totally makes sense. And I think working with someone who's experienced and board certified in obesity medicine also helps to minimize your risk because they're looking at you as an individual patient and not a one size fits all. And that's why you get the expert. Okay,
Yes.
let's go to. So we've talked about the bad things that can happen. Well, let's talk about. Tell me about the story of a patient who had an amazing outcome. Well, we already kind of talked about that a little bit, my patient.
Yes.
But let's talk about a different patient. The story of a patient of yours who had an amazing outcome after being under your care.
Okay. So, I have this person who comes to mind. She's a middle-aged woman, dealt with weight her whole life, and she needed multiple joints replaced. She needed a hip, she needed a knee or two. And she just was losing weight on her own. She was tracking in my fitness pal. She was trying to be more active, and she had lost a certain amount of weight. I wasn't prepared. I don't have her data right in front of me, but and then she was stuck, right? Because that's
Yeah,
when the
plateau.
brain said we're done.
Yeah.
And even though she was restricting more and exercising more, no more weight loss. So her surgeon referred her to me, and I said, okay, this is what we need to do. And we discussed the proper nutrition strategies or activity strategies, the behavioral component, and then we got her started on some anti-obesity medications. And lo and behold, she had that first hip surgery done, within, I think she started with me in September, and I think she had her first surgery in March.
Hmm.
So she got her BMI under the threshold, which seemed impossible at the time. I think she lost like 20% of her, 15 to 20%. I should have been more prepared, but 15 to 20%. And then she was, had her surgery, so there's a little bit of bump, but then she started losing more, and then so much more that 3 months later, then she got her other. So she went from her knee, and then she had her hip done. And between surgeries, she continued to lose that weight,
Wow. Good for
right? And then
her.
after that surgery, what I see sometimes is people are so focused on the surgery that once they get that surgery done,
Hmm.
that there may be less of a priority on these things. But she was on one of these GLP-1 medications.
Yeah.
She was very religious about tracking her food, as she actually still is to this day. And, this was maybe 2 or 3 years ago, maybe more.
Hmm.
And she's continued to lose and maintain that
Wow.
weight loss. I
Hmm.
think she's anywhere from 25 to 30%. I'll share, I'll send you a copy of
Okay.
her weight
Okay.
graph.
Okay.
And
Wow.
the show her,
That's
and we meet less frequently now. She's still on the medicine. In the beginning, I meet with you very frequently, and
yes.
now I meet with her quarterly, right, to make sure, kind of like a heart attack. You see the cardiologist very frequently, and then you maintain some
Yes.
regular care,
Yeah.
right? So, and then if someone's struggling because there's various life stress
Yeah.
changes, then we meet more often if we're struggling
Yeah.
a little bit more with
Yes.
controlling and managing it. But she's doing great today.
Yeah.
If you ask her, she'd still like to lose a little bit more, but I think
Yeah.
compared to where she started, it's like night and day. Some people don't
Wow.
recognize her.
Wow. That's amazing. And it's really amazing for her to have maintained that consistency through kind of the stress of the surgery in between multiple surgeries and still kind of have the wherewithal to say, hey, I'm on this track. And I think that's
Yes.
kind of, I mean, I hate to say that you're a coach, but having
Oh,
basically
definitely.
like a coach, right, who's
Yes.
able to kind of handhold you through that process so that you get the
Mhm.
outcome that you both kind of desire. So kudos to both of you. And because that is not easy, right? When you're dealing with the pain of surgery, that's all your brain can think about. So having to kind of be consistent and committed to this path of weight loss in between and throughout all these surgeries,
Yes.
I give her full kudos. So well done, both of you. It takes a
Oh,
team.
well, thanks. I always say I'm the coach. She's the one
Yes.
who has to do it, right? So she's
Yeah.
the consistency, but also the medications make it easier to stick
Yeah.
with your plan,
Yeah.
and
Hmm.
they make it a little more forgiving if you have some,
For
if
cheat
you
days.
have some period of life or struggle too.
Yes. Yeah.
That's why they're long-term use. Yeah,
Yeah.
for
Yeah.
sure.
So if you had a superpower, what would it be? Tell me.
Oh my gosh. Okay. So there's so many different things, but the one that sticks out to me the most is I would love to go back in time
Yes.
and talk to myself in my 20s
Mm,
and maybe even younger. First off, educate myself on what I know now about the
mm,
disease of obesity so
mm,
I could perhaps change some of my own personal choices and
mm-hmm.
activities and beliefs about myself.
Yes.
And I would also urge my younger self to study the disease of obesity much earlier and get
Mm-hmm.
into this field much earlier.
Yeah.
But I don't regret being a family doctor for 13 years before
Yeah.
I started doing this
Yeah.
7 years ago, because I think that makes me fully capable of what I do now.
Yeah. I love it.
But
Yeah.
yeah, I would go back and I would
Yeah.
that's what I would do.
That's a great answer. Yeah, that's great. Yeah, that's a great superpower to have. When
Right?
you go back,
Hindsight's
yeah.
always 20/20,
It
right? If only
is,
you knew.
right?
Yeah.
Yeah, yeah.
Uh-huh.
Imagine, yeah, all that. Yeah, I mean, and I think as women, we've all gone through that, whether it's having when you're having the babies or those teenage,
Hmm.
hormonal issues and,
Oh yeah.
going to med school, which for me was a very stressful, high cortisol
Yes.
my
Me
life.
too. Me too. Yeah. I
So
don't I don't know anyone that it's not.
yeah,
Trust
So yeah. So, well, thank you so much, Dr. Alexis David, because you really kind of did an in-depth overview of, why we're dealing with obesity as a disease and, understanding it's not just a matter of your willpower. We talked about the factors that contribute to it, medications, what's effective, and, and examples of people who've been successful. And that is why you are one of our top choices when it comes to having patients that need care in obesity medicine, obesity as a disease to kind of see you. So if you are in the greater Seattle area and you know anyone who is struggling with obesity, please share this video. Tell us, Dr. Alexis David, how can people find you?
The best way to get started or to meet with me would be to go to my website. That's premiermwm.com. So premiermwm.com. And there you can read all about my program. There's an initial consult option if you're not sure if you want to commit to the program. There's also an option to say, you know what, just I heard this, I'm ready to go, let me get started. The consult is not a requirement to get started, but it's a way for someone to get to meet me and help me answer some of the questions they may have about it. But that would be the best way. And then my assistant will get back to you to help get you scheduled.
Okay, fantastic. So we are going to put the social media links. So Dr. Alexis David has a Facebook link and Instagram as well, and she's also on LinkedIn. So we will have those added kind of to the show notes. Dr. Alexis David, thank you so much because this is like after hours in Seattle, and I appreciate you kind of staying late at work to kind of talk to our audience about, what's going on in the world of obesity and really kind of fine-tuning our thoughts. And no, it's not because you have poor willpower. There are things going on in your brain. That little thermostat is saying you will not die of starvation.
No.
That will not happen to you.
Yep.
Well, thank you so much, Dr. Alexis David. Thank you, everybody, for listening, and see you next time on the Healthy Joints, Healthy Lifestyle. Please share this video with anybody that you think would benefit. Have a wonderful day, everybody.